Alright, welcome back everybody. So it's been a while since I've been live, and finishing up this respiratory stuff is taking some time only because of my new job, which has been really fun. I've been putting together a bunch of ideas of things to stream while I drive either to or from work, because it's usually like a 20-minute drive, which is enough time for me to talk and babble about pretty much many things that I enjoy talking about, right? I talk about a lot of things amongst my friends, like religion versus culture, how to be a gentleman, how to date correctly, all kinds of weird things that are pretty popular conversations amongst many circles that I'm part of. And then the whole idea of just being a good person, things I'm into, and more personal stuff. So that's stuff that's going to be coming along. But right now, we just need to finish up this full mastery playlist, because this playlist is the link that I kind of give to people that email me saying, "Hey, I'm new to step 1 prep. What should I do? How should I approach the preparation?" And I tell everyone pretty much just to go through the entire playlist the way it is, right from beginning to end, doing biochem, immuno, path, all of that, and then all the systems also in the same exact order as it is in first aid. Even though it's an ABC order, it just works out perfectly the way it is, because revision is easier, and it really wouldn't make sense to per se start with respiratory. For example, starting with cardio is actually perfect. Cardiovascular, hemonc, the whole order of things that first aid has it is the way to do it. By the time you get to respiratory, things just start making much more sense, and then you try to learn the actual respiratory physio that we've been talking about in our last few videos. So these newer respiratory videos that I've been doing lately are pretty much perfect, because I've been able to describe and explain all the different pathologies and the physios of things that occur with respiration with minimal mistakes. So I wanted to start off this video with a couple questions that are on this blank page right here, where we'll look at some things relevant to what we've been covering up to so far, and then just finish off respiratory physiology with carbon dioxide transport. And that'll be it for respiratory physio. So let's dive right into it. So as usual, always make sure you know all your normal stuff, right? Very important to know the normals. Very important to know this image right here, also giving you all your different normal values, right? This is how it needs to be, and if any of these numbers change, then you know immediately something is wrong. So let's take a look at this question right here. So, 45-year-old man comes to the emergency department with a 1-day history of severe dyspnea on exertion. The dyspnea has been worsening throughout the day and has been occurring with progressively shorter walking distances. He reports no inciting trauma. He has no other medical problems and takes no medications. He has a 20-pack-year smoking history but does not use alcohol or drugs. His blood pressure is 110/60, pulse is 96. ABG drawn on room air show a PaO2 of 54 and PaCO2 of 26, right? So now already we're starting to see numbers that don't quite seem right. What is the most likely cause of this ABG abnormality seen, right? So he has severe dyspnea on exertion. He has dyspnea that's been worsening and occurs with short walking distances, so he just cannot breathe no matter how much he's trying to. He smokes a lot, so that's definitely something that's pretty bad in his history, right? 20-pack-year smoking history, and then they didn't really give you much else. So now how do you figure out what's wrong with this guy, right? And it all comes from just the PaO2 and PaCO2 values they gave you. That's literally all you could work off of, right? So when we look at the normal values here, right, the CO2 you can just remember 40 for everything alveolar and arterial. And then oxygen, you want to have a high number, right? You want to have what we call 100% oxygen, basically, so you can remember the hundreds. And his oxygen is pretty much halved, and he's also got lower CO2 values here, right? So this is not working out too well, and his ABG abnormality, it's unfortunate that I can't have the other answer choices here, but of those answer choices, the best explanation for his arterial blood gas abnormalities was alveolar hyperventilation. And then they gave this image with it to explain it. So let's take a look at what's happening. This patient's acute onset dyspnea, hypoxemia, and hypocapnia are consistent with alveolar hyperventilation. Arterial CO2 is inversely related to and considered to be the main indicator of total alveolar ventilation. Assuming a normal rate of metabolic CO2 production, Hypocapnia implies alveolar hyperventilation, and that's just something you have to know. If you have hypocapnia and the patient's CO2 production is normal, right? They don't have excess CO2 production, nor do they have low amounts of CO2 production. That doesn't really occur commonly. So as long as you're making the right amounts of CO2, if your arterial CO2 is low, then you must not be ventilating with enough time. You're hyperventilating. You're just going too quickly. And what happens when you hyperventilate? You breathe out a lot of CO2, right? You just lose your CO2 very, very quickly, and that ends up being a problem. They go on to explain alveolar hyperventilation can result from VQ mismatches, ventilation perfusion mismatches, that cause decreased oxygen and CO2 exchange, like pneumonia or pulmonary embolism. The resultant hypoxemia stimulates peripheral chemoreceptors and increases the respiratory drive above normal levels, so you start breathing quicker, right? So this patient, although we don't know for sure, could have had a pulmonary embolism. They do have the smoking history to undergo a pulmonary embolism by some chance. This leads to excessive CO2 excretion by the lungs, resulting in hypocapnia. You lose all your CO2. CO2 is basically acidic, so this leads to respiratory alkalosis. However, hypoxemia persists since the blood flowing through highly oxygenated lungs cannot absorb the extra oxygen to compensate for the hypoxemic blood returning from poorly oxygenated regions. This causes an increased alveolar arterial gradient, which can be treated with oxygen and by correcting the underlying disease process, which might be a pulmonary embolism for this patient. Without treatment, persistent tachypnea will lead to eventual respiratory muscle fatigue, hypoventilation, and hypercapnia. Right, so this guy really needs help pretty quickly. But the main thing is to remember from this question that PaCO2 is inversely related to and considered to be the main indicator of alveolar ventilation. If PaCO2 is high, right, and here his PaCO2 is low, but if PaCO2 is high, then inversely related to alveolar ventilation, so you would be hypoventilating. If PaCO2 is low, like our patient, then you must be hyperventilating. Inverse relation right there. And that just gives away the answer to you. And that's literally all you had to work off of for this question too. In the graph that they provided in the explanation, many people saw this graph, didn't really know what to think of it, right? For our patient, it's the red dots. The red dots is where our patient is, right? So he has a low CO2 value. He also has a very low PaO2 value. So what are they explaining here? For up here, they tell you blood does not become saturated with CO2. Highly ventilated regions can compensate for less ventilated regions, right? Your blood does not become saturated with CO2. When you hyperventilate too quickly, there's no time for that gas exchange to occur correctly. Same thing here too. Blood quickly becomes saturated with oxygen. Highly ventilated regions cannot compensate for less ventilated regions. And this guy has some region, like over here, right? From this image, this isn't related to this question, but he might have one of these regions that are messed up in this guy, and whatever that region is, he cannot do anything there no matter how much he hyperventilates, right? So his hyperventilation is only causing him to lose CO2, but it's not replenishing his oxygen at all, right? So any case scenario of low VQs will be problematic. This other question here is a similar thing also, and then it does a good job showing you how you work with a VQ scan. So they tell you a 56-year-old man is evaluated for dyspnea and chest discomfort. Medical history includes hypertension, type 2 diabetes, and chronic kidney disease. Temperature is a little high, 100. Blood pressure is 160/90, which is definitely very high. Pulse is 98, respiratory rate is 24, and he's overweight, BMI 31. He undergoes a 2-part nuclear medicine test. During the first part, he breathes in a radioactive tracer and a lung scan is performed. In the second part of the test, he is given an IV injection of a different radioactive material while breathing normal air, and the scan is repeated. Right, so that's basically describing how a VQ scan is done. When the images are compared, a large area of the lower right lung is not visualized, and that's kind of what you can see here. The lower right lung is just not really being seen compared to normal. Based on the observed findings, what disease process is most likely present in this patient? Well, if you can't see it, that means that whatever he's breathing in is not reaching that area, right? And for this patient, the best answer to pick was a DVT. Also because they were doing a VQ scan, so you had to pick an answer choice that had to do with some kind of VQ mismatch, right? The image to the right was given. This patient with dyspnea, chest discomfort, and a perfusion defect on VQ scan most likely has a pulmonary embolism, probably caused by a DVT in the lower extremities, right? So he had a perfusion defect, and the only answer choice that in this list of answer choices for that question that had anything to do with the perfusion defect was a DVT. Other answer choices could have been something like pneumonia, COPD, etc., and those would not be correct answer choices for this kind of scenario. All right. So this two-part test that they did is very important to understand. Right. The first part was him breathing in radioactive tracer, and then the second part he's given an IV injection. Right. So whatever he's breathing is gonna go in one place. The IV injection stuff is gonna go through the blood. For him, when the images are compared, a large area of the lower right lung is not visualized in the scan, right? And since that's the only area not being visualized, but and then this isn't per se his VQ scan. This is just showing you an unmatched perfusion defect with multiple things even in the left lung. But generally speaking, if you have something like this occur, like this VQ scan over here, this is an unmatched perfusion defect, right? This one. And for our patient, he had that same exact issue, the unmatched perfusion defect. His blood supply to the lungs is somehow messed up, and it has to be because of a DVT causing a pulmonary embolism, which would then block the blood flow like this. Right, so this area, per se, would not necessarily show up correctly on a VQ scan. Let me just search for something real quick. Unmatched ventilation defect VQ scan. Let me type scan. I just want to see if there's there's definitely a bunch of shit. So looking at this stuff here, right, so you can see how the two things look different, right? Ventilation versus perfusion. But I want to see what a scan difference would be if there's someone who has an unmatched ventilation defect. From what I've studied so far, I know that people who have unmatched perfusion defects, it's okay. If we look at this stuff right here, right, so you can see how perfusion defects usually cause like a patchy loss of tracer, right? Patchy loss of tracer, because perfusion is blood vessels, and blood vessels are intricate. So depending on where specifically the blood vessel is not supplying blood, you just end up losing a random patch. Okay. With ventilation defects, you're going to have an entire area that's one area and it's not patchy, just not getting any actual ventilation. Air is not reaching that lobe, right? And that's a different kind of thing that can occur in other people. So I can't really see something like the one that UWorld is showing per se. This is the best one. Unmatched ventilation defect. All right, so this is lung perfusion defect. These are all different lung perfusion defects, and you can see how it's all patchy loss, right? This is all different kinds of patchy losses depending on how bad the perfusion is messed up. All right. Obstructive airway disease, both perfusion and ventilation. Right, so A and B, both ventilation and perfusion images show multiple peripheral defects which are matched. All right. So hopefully, whenever you get your VQ scans on your test, you'll be able to understand whether it's a ventilation defect or a perfusion defect. Right, but very important to go ahead and really make sure you know what's happening when you wanna start studying for this kind of stuff on your test. And if you see more questions, that'll obviously help for sure too. But just remember that perfusion defects are usually going to be patchy losses because of how intricate blood vessels are. Alright, so definitely many images out there to look at. If I find anything later on, I'll come back and talk about it in the next video. But definitely worth knowing. You don't want to get it wrong. So if you see something like this where it's patchy loss, just like this red arrows are showing, that is an unmatched perfusion defect. Now we have an AMBOSS question. It says a 63-year-old man comes to the physician because of a 2-day history of fever and blood-tinged sputum. He also has had a productive cough for 1 year and has had 3 episodes of sinusitis during this time. Physical exam shows palpable erythematous skin lesions over his hands and feet that do not blanch on pressure. There are ulcerations of the nasopharyngeal mucosa and a perforation of the nasal septum. His serum creatinine is 2.6. He has kidney issues as well. Urinalysis shows acanthocytes, 70 red blood cells, 2 plus proteinuria, and red blood cell casts. An X-ray of the chest shows multiple cavitating nodular lesions bilaterally. So this is a very UWorld type question on AMBOSS. They gave you everything to be able to figure out exactly what's wrong with this patient. Further evaluation of this patient is most likely to show which of the following. And then you look at your answer choices and you see C-ANCA there and other things, of course. Each answer choice you see should ring a bell for a specific set of diagnoses. And looking at C-ANCA as an answer choice, it should just come to your mind that all the things this patient is presenting with fit that one disease. So this patient shows the classic triad of GPA, granulomatosis with polyangiitis, right? He has polyangiitis, he has granulomatosis, and granulomatosis with polyangiitis has many things to it. Mainly, it has a necrotizing vasculitis, which has the palpable purpura. It has upper and lower respiratory tract manifestations, which is his chronic sinusitis, nasal ulcers, hemoptysis, and nodular cavities in the lung. And, of course, he has renal issues, glomerulonephritis or nephritic syndrome, right? Those three things in the same patient is a C-ANCA-induced granulomatosis with polyangiitis. Approximately 90% of patients with active GPA and about 65% of patients with inactive GPA have high C-ANCA titers due to antibodies against proteinase 3. A biopsy of affected tissue, such as in the nasopharynx, should be obtained to confirm the diagnosis, showing necrotic, partially granulomatous vasculitis. An indirect immunofluorescence of the biopsy sample would show C-ANCA antibodies as a granular pattern of fluorescence limited to the cytoplasm, which is why it's called C-ANCA. And we discussed C-ANCA and the other diseases that were relevant to this set of diagnoses in cardiology, right? Under cardiology, I call it Wechner, right? So this is a mnemonic that a couple people suggested, and it was all over the internet. So you could spell Wechner's with the G being replaced with a C, and the WE is for two people, which is for two segments, upper and lower respiratory tracts. The C in Wechner is to remind you of C-ANCA, and the R at the end, right? Everything I capitalized here, the R at the end is to remind you for renal. Alright, so you're going to see upper and lower respiratory and renal. As long as you can catch that much, you should be able to make the diagnosis. The necrotizing vasculitis would be the third thing that you would have to catch. Remember, its other name is granulomatosis with polyangiitis, so there are granulomas and there will be cavitary lesions in the lower respiratory tract. Right? This is a cardiology thing that comes back full circle to respiratory as well. Right? You can get a respiratory question that can shift gears to a cardiovascular type of question, and vice versa. They love doing this on step 1, so be ready for that. This was also a really good question, so let's look at these last two and then we'll be done with the practice questions relevant to BQ mismatches and respiratory stuff. A 72-year-old man with coronary artery disease, right? So we're starting with cardiovascular thing here. Coronary artery disease comes to the emergency department because of chest pain and shortness of breath for the past 3 hours. Troponin levels are elevated, and an ECG shows ST elevations in the precordial leads. And that gives away the fact that he has an MI, right? And it's the ST elevation. That means that it's a transmural MI. ST depression would be a depressing thing. So you're hurt from inside, which means that you have only inside. The inner wall of the heart is MI'd. But ST elevation is a big deal. It's elevated, so that means that you have a transmural MI. Revascularization with percutaneous coronary intervention, PCI, is performed and a stent is successfully placed in the LAD. 2 days later, he complains of worsening shortness of breath. Pulse oximetry on 3 liters of nasal cannula shows an oxygen saturation of only 89%. An X-ray of the chest shows distended pulmonary veins, small horizontal lines at the lung bases, and blunting of the costophrenic angles bilaterally. Right? So instead of giving you the chest X-ray, right, here they're describing what you see in the chest X-ray, which in essence is better than giving you the chest X-ray, because many people who have not studied it wouldn't really see it. You wouldn't per se see the small horizontal lines, which have a name. They're called curly B lines. We're going to see that later on when we get to respiratory path questions, right? I have a bunch of practice questions in respiratory path also from AMBOSS. where you're going to see the x-rays, and the curly B lines are going to be highlighted because that was something really cool Amboss did. So then they go on to ask you, which of the following findings would be most likely on a ventilation perfusion scan of this patient? If we did a VQ scan, and you would have normal perfusion with bilateral ventilation defects, right? So this patient would have ventilation defects, which is different from the other question we did. Right, so what are we going to see here? Why does this guy have ventilation defects and not a perfusion defect? Well, the combination of a recent MI, worsening dyspnea, and the chest x-ray findings showing pulmonary vein congestion, curly B lines, and pleural effusions, right? The claustrophrenic angles being blunted is a sign of pleural effusion. All of that should raise suspicions for cardiogenic pulmonary edema, which means that blood in the heart is backing up into the lungs, right? Blood is backing up into the lungs. Areas with normal perfusion and no ventilation are seen in patients with cardiogenic pulmonary edema, right? Perfusion is going to be normal. However, there's no ventilation there now, right? Elevated pulmonary venous pressures secondary to decreased left ventricular function, right, which is why this is cardiogenic pulmonary edema, result in increased amounts of intra-alveolar fluid, which leads to impaired ventilation, right? If there's too much fluid there, how are you going to have gas exchange? No air is going to reach that area of the lung. Insufficiently oxygenated blood from parts of the lungs that are not ventilated mixes with the oxygenated blood from ventilated parts, resulting in an overall decrease in PaO2, which for him, his oxygen saturation is presenting with 89%. You also get an increased AA gradient because the VQ mismatch is doing that, and systemic hypoxemia. 45% of people chose normal ventilation with multiple bilateral perfusion defects, which is the wrong answer choice, right? Only 35% of people got this correct, which was normal perfusion with bilateral ventilation defects. So how do you avoid that mistake? Well, the other question we did earlier, this one over here with the DVT, he's the one that had multiple defects in actual perfusion, blood flow, right? How do you get normal ventilation with multiple bilateral perfusion defects? The pattern of normal ventilation with perfusion defects can be seen in patients with pulmonary emboli, just like the other guy with the DVT, same thing. Blood clots obstruct lung arteries and subsequently cause decreased perfusion. As there is no airway obstruction, ventilation will be fine. This patient's dyspnea could indicate pulmonary embolism, like our 72-year-old. However, his x-ray findings and the history of a recent MI suggest pulmonary edema. So everything comes together to really give you the answer, right? If you have a DVT or a pulmonary embolism, that's going to be a perfusion defect. Blood's not going to flow correctly. But if you have pulmonary edema, which was given from his chest x-ray and his history of an MI, right? His ST elevation, elevated troponins, pleural effusions, blunting the claustrophrenic angles, all of that comes together to tell you that he has cardiogenic pulmonary edema. Everything's backing up into the lungs. Now the lungs are full of water, basically, full of fluid, not water really, but full of fluid. So now that the lungs are full of fluid, blood flow is okay. It's just that air ventilation is not going to per se work, right? And that's what this guy's issue was, bilateral ventilation defects, not bilateral perfusion defects. Remember that the lung is different compared to other organs. When the lung does not get enough oxygen to a certain part, then blood is shunted away from that source to more oxygenated areas, while in other organs, blood is shunted toward areas that have low oxygen, so you can bring it more oxygen. So people forgot that and chose the wrong answer. Ventilation is about the lungs alveoli, and in pulmonary edema, there is fluid in the alveoli, so ventilation is abnormal. And we saw that over here. One of these things, like kind of like this right here. So you can see how blood flow is normal, right? Blood flow is normal, but because this one is full of fluid, ventilation is messed up, right? Up here, this is all ventilation, this is all perfusion, right? Ventilation is all air and alveoli and breathing in, right? Air vents. Perfusion is blood perfusion, right? And you can see how blood flow is perfectly normal, but ventilation gets messed up when you have fluid backing up into the lungs, right? That's not going to work too well, all right? So very important to make sure you understand that. This one is also the same thing, decreased alveolar ventilation. However, this one is a little different from what our guy has. Our guy has this, which is why he would have a high AA gradient. This image here of decreased alveolar ventilation, This occurs when you're in a high altitude, right? You're in a high altitude, so not enough air is actually coming into your lungs because of the higher pressures. And I think in the end of the last video, I said you would have to hyperventilate to fix this. That was a tiny error. What I meant to say is you would have to breathe more, not breathe quicker. So I said hyperventilate because I was thinking you would have to breathe more. When I was in Colorado, I wasn't hyperventilating. Colorado is a state in America that's at a very high altitude. Right, so when I was there, it's not that I was hyperventilating. I had to take deeper and shallow breaths, right? But slower. I would take really deep breaths, hold it, slowly breathe it out, and so on and so on to adjust with the higher pressures that I was in. Okay, so that was a tiny mistake at the end of the last video. I said you would have to hyperventilate. But in my mind, I was really just thinking of breathing more, not per se breathing quicker. Alright, so that's it for those practice questions. One last one, and then we're going to wrap up carbon dioxide transport physiology, and that'll be the end of respiratory physiology. So this question says, a 19-year-old male soccer player undergoes an exercise tolerance test to measure his maximal oxygen uptake during exercise. Which of the following changes are most likely to occur during exercise? Right, so what occurs during exercise? And that's basically all this is asking. Now, this is a pretty big deal because what occurs in normal people is always asked on step one, right? Normal people with exercise, normal people who are just aging, right? Normal things that are not per se pathological. Excuse me. So here the answer was decreased physiologic dead space, right? 40% of people were able to get it correct, but 31% of people chose an increased apical VQ ratio, which I still don't per se understand why someone would choose that, but obviously that comes from a lack of understanding, right? That's really all it kind of was. So you have a young guy, right, 19-year-old, so he's perfectly fine. They don't tell you any kind of pathology for him. Nothing's wrong with him. He's just going through exercise, and you're going to see what happens. So physiologic dead space consists of the anatomic dead space and the alveolar dead space, two things, right? In the resting state, the majority of pulmonary blood flow goes to the base of the lungs due to gravity, and therefore alveolar dead space primarily localizes to the lung apices, right? And that's kind of the concept where maybe 31% chose increased apical VQ ratio, but the wording apical VQ ratio is incorrect. During exercise, vasodilation of the pulmonary vessels in the apices occurs too. Additionally, the increased right ventricular cardiac output increases pulmonary circulatory pressure, allowing the opening of apical blood vessels that were collapsed at rest. These processes increase apical lung perfusion, and this entire concept would decrease the apical VQ ratio, not raise it, right? The ratio would only get bigger if the difference is bigger, which is normal. The difference normally is big. Normally up here we don't really have much ventilation and perfusion happening, right? Because there's air, but there isn't really much blood at the top of our lungs. When you exercise, all your blood vessels dilate, right? Everything gets really, really thick and big because you want to send blood everywhere. So you get more blood to the top, and that kind of equalizes the ventilation perfusion. So maybe it was like a really low ratio, a really high ratio before. Now it's going to get lower because you only had blood at the bottom of your lungs. Now you're going to have blood in the whole of your lungs. So that's going to normalize the ratio, not increase it. All right. So this decreases alveolar dead space and decreases physiologic dead space because now your dead spaces up here that were physiological are being used also. Your lungs start using as much of their lungs as they can to help you fix everything. At rest, the VQ ratio is higher at the apex, like a 3, right? There's a high ratio because ventilation might be like 30, but perfusion might only be 10, right? So 30 divided by 10 is 3. This is because the majority of pulmonary blood flow goes to the base of your lungs. limiting perfusion to the lung apices. Exercise increases both ventilation and perfusion to the apices, but perfusion increases much more. Right? Ventilation was already pretty high to begin with, so now maybe it'll be a 40 ventilation at the top of your lungs, but perfusion might also be about 35. Right? That makes the ratio almost 1. Right? So the ratio became lower. Right? Plugging in numbers really helps you see. So ventilation versus perfusion. Right? So exercise decreases your apical VQ ratio. It also decreases how much dead space you have. You obviously want to use the entirety of your lungs to be able to work out correctly. Right? So now that we're done talking about all of that stuff, right, make sure you're able to review this and kind of talk about it. Especially one thing we had done in our last video, really cool question. Let me see, where was it? Oh yeah, this one right here, right? This question at the bottom, the 55-year-old man. Understanding what a matched ventilation perfusion defect is. What is a ventilation defect without a perfusion defect? And of course the other one too, what is a perfusion defect? What is a perfusion defect without an associated ventilation defect? All three different types of things were discussed in this question, right? Then we looked at a bunch of graphs kind of showing you ventilation versus perfusion. We understood how the numbers all work and what they mean, right? We talked about the left to right shunt, and today we talked about VQ scans, what those VQ scans tell you, and we looked at a similar thing again. Normal perfusion with bilateral ventilation on a VQ scan, or normal ventilation with multiple bilateral perfusion defects, right? The difference between the two things, why one person would have one of those things and the other thing or whatever, right? Make sure you're able to differentiate that, because that's kind of what you're going to get questions on. This last topic is a pretty easy, fairly simple topic that you just need to make sure you understand, so that you need to understand it enough to be able to answer questions. You don't need to know it fully though. It's not the craziest thing. But many people go into step 1 with a pretty weak understanding of how the entire carbon dioxide transport thing works, right? And part of it is also because first aid wasn't really complete enough to talk about it all. It's really important to understand how the Bohr-Haldane effect helps. What do they do? And then where each thing occurs. So CO2 is transported from tissues to lungs in 3 different forms. Majority of it is as bicarbonate, and we've talked about bicarb endlessly, right? Especially when we did a lot of renal. The other form is carb-amino-hemoglobin, right? HbCO2, which is about a quarter of your CO2 transport. CO2 bound to hemoglobin at the end terminus of globin, not heme, right? Because heme binds oxygen. CO2 favors the deoxygenated form, which means that CO2 favors binding to hemoglobin that just dropped off oxygen, which makes sense, right? Because where does hemoglobin drop off oxygen? At muscles, right? Any hemoglobin that just dropped off oxygen will now pick up CO2 and go back to the lungs to pick up new oxygen and release CO2, all right? And then the small amount of dissolved CO2 that's just floating around and makes its way around your body. In lungs, oxygenation of hemoglobin promotes the dissociation of H plus from hemoglobin. This shifts the equilibrium towards CO2 formation. Therefore, CO2 is released from the red blood cells. And that is your Haldane effect, right? Very important to know which one is which, right? The difference between the two effects. So CO2 being released from the red blood cells in your lungs, that's your Haldane effect. And we're going to see that in all the pictures we have here, right? So you can see in this image, for example, if you're looking at alveoli, right, and CO2 being disposed of from the red blood cell into the alveoli, that's your Haldane effect. Okay, why does this happen? This is occurring because of the H plus. Remember that when oxygen comes into hemoglobin and you make oxyhemoglobin, you release an H plus. That H plus allows you to get rid of CO2 by also forming water. Right, so very straightforward thing. These things are shown in these images very nicely, right? It's not per se perfectly shown in first aid, but they did a pretty good job as well. But in combination with UWorld images and other concepts, it becomes a lot easier. All right. So the hemoglobin that's red is the oxyhemoglobin. The blue one for venous blood, basically. The blue one is deoxyhemoglobin. Right. So when this deoxyhemoglobin picks up in oxygen, it becomes oxyhemoglobin and it releases an H plus. That H plus connects with bicarb to make H2CO3, right? And that's where carbonic anhydrase is a very important enzyme, because here this is the opposite form. In this form right here, you basically just release CO2 and make water. Right? Super straightforward stuff. Nothing crazy is happening here. So that's your Haldane effect. The Bohr effect is the opposite one. The Bohr effect is kind of what they're showing you here in first aid, right? Because now you're not looking at alveoli, you're looking at tissue, right? So this could be muscle, this could be anything. You can see how the muscle, let's say this is muscle tissue, you can see how the muscle is releasing CO2, right? And that CO2 is being picked up by this red blood cell, which is now going to bring it back to the lungs, okay? In peripheral tissue, and that's what they're describing now, the Bohr effect. In peripheral tissue, high H plus from tissue metabolism shifts the curve to the right. And we've talked about the left and right shifts, right? When high H plus, remember high H plus is low pH, right? But we don't say low pH, we talk about high H plus because we want everything high to shift the curve to the right. Everything when it's low, it shifts the curve to the left. High H plus shifts the curve to the right, unloading oxygen, right? Because acidic stuff is obviously, you could think of it as acid breaking the hemoglobin and releasing oxygen, something like that. Right, so unloading oxygen, and that's your Bohr effect. That's kind of what's happening in this image, right? But in this image, they don't really show you the oxygen being unloaded, right? So that's why I don't really necessarily like the image that first aid has. It's very incomplete. This image just does one thing. It kind of shows you carbonic anhydrase and some basic equations with 1, 2, and 3 telling you the things that are occurring here. Right, but they didn't even label this one here as the chloride shift, which is very important. This is the chloride shift, and I put that right there, right? So very important to know that. We're going to see why that's important when we do this question right here. But let's take a closer look at the Bohr effect. So that's this left half of the image. So let me make it bigger. So in the left half of this image, you can see now you have peripheral tissue that's making CO2. CO2 comes in to the endothelium, into your blood vessels, goes into the red blood cell, right, and then combines with water, and you're going to have carbonic anhydrase doing a bunch of shit here too. And of course, since you're at peripheral tissue, that peripheral tissue wants oxygen, right? So your oxyhemoglobin becomes deoxyhemoglobin, unloads oxygen. All right, so when you see something like this left image, that's your Bohr effect, right? High PCO2, high H plus concentration. You could think of this as lactic acid, because we're talking about muscle, right? So if we consider this a very active muscle has high lactate concentrations, which is why we feel the fatigue and burning sensation. That stops us from continuing to like the 99th rep of any kind of workout. And that acidity basically causes oxygen to be released, hemoglobin affinity decreases, right? And when oxygen is unloaded or deoxyhemoglobin is exactly what CO2 prefers. So CO2 gets onto it, right? This is now going to go to your alveoli and release the CO2 and pick up new oxygen. That's the Haldane effect. Right? So Bohr and Haldane, very different, basically reverses of each other. Now, what is the chloride shift? So the chloride shift is how bicarb comes out and chloride goes in, and that's what this question over here is about. So UWorld said it has been determined in healthy volunteers that the chloride content of red blood cells is much lower in arterial blood than in venous blood. What is responsible for this observation? So this observation is something you should know, right? So arterial blood has lower chloride concentrations, okay? And why is that happening is what they're asking you about, right? Much lower in arterial blood than in venous blood. So the answer was carbonic anhydrase, which I don't know if that's exactly the answer per se. Like, it shouldn't be carbonic anhydrase, but I'm sure from all the other answer choices, that was the best thing to pick. But the concept is that when bicarbonate ions diffuse out of the red blood cell into the plasma, chloride ions diffuse into the red blood cell to maintain electrical neutrality. Right? One negative thing came out, so another negative thing went in. This is called the chloride shift, and it is the main cause of high chloride in venous blood, right? This is going to be now venous blood because you're basically at the muscle, you've unloaded oxygen, so now this is deoxygenated hemoglobin, right? And venous blood is where your hemoglobin doesn't have much oxygen in it. In arteries, bicarb enters the red blood cell as red blood cell drops off oxygen and picks up CO2 in the form of bicarbonate. All right. So very important to make sure you're able to understand the difference between those things. So always remember, arterial blood has low chloride. Venous blood has high chloride. Right. And this is just me breaking down the board and how they affect. The last two things they put here are the two other basic things they ask questions about. We already did the response to exercise. We did this question, right, where we understood that you're going to have a lower VQ ratio, right? VQ ratio from apex to base becomes more uniform because perfusion in your entire lung becomes more uniform. Obviously, you're going to have more CO2 production. You're going to use up more oxygen. Ventilation rate meets oxygen demand, right? So you breathe faster when you exercise. You're going to have acidity, like lactic acidosis, because you're exercising. No change in PaO2, PaCO2. But there will be an increase in venous CO2 content and a decrease in venous oxygen content, right? Because you're using up all your oxygen and you're making a lot of CO2. But PaO2 and PaCO2 should not per se change. Very important to remember that, right? That's response to exercise. Completely normal thing. A bunch of basic text here that you can pause and read about, but straightforward information. You can get a confusing question on response to exercise, what happens when a normal healthy individual exercises, so make sure you know this. Response to high altitude is the other thing we just talked about, right? About my experience in Colorado. So decreased atmospheric oxygen leads to increased ventilation. And this is why in the last video I said hyperventilation per se, but you don't necessarily hyperventilate. Not exactly. You just need to take deeper breaths. That's what you have to do. But some people might hyperventilate because they don't know that you should just take deeper breaths. In fact, at first I was hyperventilating also. What was I doing? When I was in Colorado, I was living at a friend's house and they had dogs. And I would play around with the dogs sometimes, right? I'd be chasing them around in the backyard and whatnot. And I would start hyperventilating like crazy as if I just ran a marathon, right? And that wasn't really helping me though. I wasn't feeling better. And then my friend told me just take deeper breaths, deeper shallow breaths, and you'll be better. And it definitely worked out. But it is a concept, right? You do end up at some point hyperventilating because you don't know how to adapt to the high altitude. And that can cause respiratory alkalosis, which is basically altitude sickness, right? Respiratory alkalosis has a pH of more than 7.45, a low PaCO2, and a low PaO2, with bicarb being normal until after 48 hours, right? Because fixing the metabolic compensation, the metabolic compensation takes time, right? So this can chronically occur, and then of course if it does occur chronically, you adapt to it. How do you adapt to it? First, you're going to have more red blood cell formation, right? You're going to have an increase in 2,3-BPG, which binds the hemoglobin, causing a rightward shift of the oxygen dissociation curve so that hemoglobin can release more oxygen, which this last thing here, this one here, doesn't really help much because you're going to have a rightward shift of kind of dissociating more oxygen, but you don't have oxygen. You don't really have much oxygen to begin with. It's not like your hemoglobin was holding the oxygen. Your hemoglobin didn't have oxygen to release. You'll also make more mitochondria, which can help with weight loss. And you're going to have an increased renal excretion of bicarb to compensate for respiratory alkalosis, but this takes a while, right? And if you're on medications like acetazolamide, that can get messed up because this carbonic anhydrase inhibitor will obviously have an effect on bicarb production. Chronic hypoxic pulmonary vasoconstriction results in pulmonary hypertension and right ventricular hypertrophy, which is a pathological thing that can occur to someone who isn't healthy enough to adapt. All right. So very important to make sure you understand how high altitude affects people. This is also, both of these things are definitely at least one question each on your step one, right? And both of these things are also very high yield topics that definitely pop up on NBME exams because they're just witty little questions that can catch you off guard, all right? And then the last thing is just an in-depth breakdown of the two effects, but I think we've pretty much got this down pretty well, right? So this here, where your red blood cell is bringing oxygen into tissues and picking up CO2, right, versus this one here with alveoli, right? Two different things. Which one is which, you have to make sure you remember. So if you're picking up oxygen from alveoli, right, that is the Haldane effect. That is the Haldane effect. And you have to make sure you remember that, because if you mess up the names, it could be a question that you'll be really mad to get wrong. If the question just asks you which effect it is, and you have Bohr and Haldane effect as answer choices, you have to be able to pick one over the other correctly, so don't mess that up. The one where you're picking up oxygen from alveoli into the red blood cell, that is your Haldane effect. Okay. The Bohr effect is the one where you're bringing back oxygen into muscles and taking CO2, right? And that's what I'm showing in a little more in depth. So these two images, this one over here for oxygen being brought to the tissue, and this one here where you're doing the Haldane effect of picking up oxygen from alveoli, are much better images than the ones that are in first aid, right? And it just shows you step-by-step breakdown of exactly what's happening, and then you get to see how the chloride shift is significant, right? Chloride shift is very significant. And that's it. That's the end of respiratory physiology. In the next video, we'll move on to respiratory path. Thank you very much for joining, and keep studying pretty hard.